All right, Chapter 9 Circulatory Responses to Exercise. All right, so looking at the cardiovascular system, obviously it's going to contain the heart. That's kind of the whole, basically the engine behind it. Then the blood vessels going out from that, also known as the vascular tree. And from there, we have the arteries that are going away from the heart and the veins that are coming to the heart. All right, now it's not necessarily that arteries, if you look at a model or look at a diagram of the heart or the vascular system, arteries aren't necessarily always going to be red and veins aren't always going to be blue. In most cases, that is the case there, but arteries are always going to be pumping blood away from the heart, and veins are going to be bringing blood to the heart. Now we also have the blood in the system. That's going to be the liquid medium for everything to kind of float around, basically part of it, dissolved in it, or part of certain products within the blood. Now the heart generates enough pressure to pump the blood to drive it throughout the vessels. And that blood flow must meet the demand for exercise, physical activity, or it will also meet the demand for being at rest. And that's also why we have a greater demand for that blood and what's in that blood, which be oxygen, carbon dioxide, as well as nutrients. We have more of a demand for that when we start exercising, actually get up, start moving around a little bit. So the blood flow increases, the heart rate increases, the amount of blood going to the tissues is going to increase. And when we rest, we get down, sit in a chair, sit in a couch, or just stop exercising, then that demand is not there to as great an extent as it was during exercise. So it will decrease. All right, so the heart itself has 4 chambers. We have a right and left atria. Those are going to be on the top. Then we also have a right and left ventricle. And the ventricles are going to be on the bottom, and they're going to be pumping blood out of the heart. All right, and the atria are going to be bringing blood in from other places, right? Either basically the rest of the body, bringing in blood from the rest of the body, or bringing it in from the lungs. Now, on the right side of the heart, and the reason I have, you might see right side is actually on, if you're looking at the screen, on the left side, and the left side is on the right side. All right. The reason is because in the anatomical position, someone facing you, the right side of their heart is going to be on your left, and the left side of their heart is going to be on your right, because the anatomical position, you're both going to be staring at each other. All right, so the right side of the heart accepts pulmonary, has pulmonary circulation, basically. So it's going to be bringing in blood from the vena cava, either superior or inferior vena cava. All right, and it's going to go into the right atria, go through a valve known as the tricuspid valve, and then into the right ventricle. And from here, it's going to pump the blood to the lungs. At this point, it's deoxygenated, meaning that there is a low content of oxygen within there, and there's also a lot of carbon dioxide. That blood needs to be pumped to the lungs so that it can drop off carbon dioxide and we can exhale it. Meanwhile, at the same time, we've inhaled some oxygen, so we're going to replace that carbon dioxide with oxygen then. Now, coming back to the heart, to the left side, the blood's going to be coming through the pulmonary veins from the lungs, and it's going to go into the left atria. It's now oxygenated, so it's oxygen rich. It's going to go through the mitral valve, basically the valve between the left atria and the left ventricle. It's going to make its way into the left ventricle and then be pumped up through the aortic valve or the aorta and then to the rest of the body. It's going to branch off from there. All right, so just a depiction of what exactly is going on. So you don't have to memorize. You don't have to really memorize all of these. All right, I'm not going to make you label anything on on exam or anything like that. But you need to know kind of how this flows, the circulatory cycle here. So the blood is coming up from the inferior or superior vena cava. So this whole vein right here is going to be the vena cava, basically accepting blood from deoxygenated blood or oxygen poor blood from the body. All right. So we've used this blood. We've used the oxygen and we've created carbon dioxide. Now the carbon dioxide is at a high concentration within this blood. It's going to enter in to the right atria, go through the tricuspid valve and into the next chamber, which is the right ventricle. Now from the right ventricle, going to be pumped up through to the pulmonary veins, or the pulmonary arteries, Go to the pulmonary veins. See how it can get a little confusing there with red and blue. Remember, veins are always coming to the heart, arteries going away. So we have the pulmonary arteries going to the lungs. Lungs are going to have oxygen there to bring into that blood, as well as we're going to start to drop off some of the carbon dioxide that we have within this blood. So now it's going to return to the heart through the pulmonary veins, go into the left atria, go through the other valve, the bicuspid valve, into the right or the left ventricle. Now, the left ventricle is sometimes known as the fuel injector of the body. So this is going to be the last place that it's going to be in the heart before it basically gets ejected to the rest of the body. In this chamber, and it's kind of depicted in this figure, if you can see the muscles surrounding, or the myocardium, the cardiac fiber muscles surrounding the left ventricle are usually a little bit thicker. Right? So this chamber is going to be fairly strong, or at least the muscles surrounding this chamber are going to be really strong to try to pump that blood out forcefully to the rest of the body, up into the aorta, and then branch off from there. Now, where does it go once it leaves the heart? So it can basically go a bunch of different places. But you can see the overall vascular tree. All right, so the blood is being pumped to the heart through the to the vena cava, either superior or inferior. And once it leaves the heart, all right, after everything's all said and done, we've oxygenated that blood. It's going to go through, and we're going to use the oxygen. We're going to be making carbon dioxide. And on the other side here, we're going to have deoxygenated blood, or oxygen poor blood. All right, so looking at that left ventricle again, it usually has the most myocardium. It has thicker walls. It pumps the blood to the rest of the body. All right, so it tries to pump as much blood as forcefully as possible, or it needs to be conditioned to be able to do that. And exercising, getting the heart rate up will cause a little bit of hypertrophy or increase in the cardiac muscle fiber cells within the left ventricle. And this is an adaptation to exercise. Now, it can be an adaptation to disease, but a lot of times that's non-advantageous. So looking at the difference down here between skeletal muscle and cardiac muscle, skeletal muscle tends to be a little bit larger and longer and unbranched, basically long, stringy fibers. And obviously, they're voluntary contractions. Cardiac fibers, on the other hand, are usually a little bit smaller. They're shorter. They're kind of branched off, right? And they're obviously involuntary contractions. Now, they're also similar to type 1 muscle fibers in that they can go for a long time. And in fact, you want your heart to work basically every day. Right? If our heart stops, that's not going to be good. Not very advantageous, not only to exercise, but living in general. So they're going to fatigue less quickly. They're going to delay fatigue a very, very, very long time versus maybe type 2 muscle fibers, especially type 2X fibers. Now, some terms that you should be aware of: diastole and systole. Diastole means relaxation. So when you say diastole, a chamber, the chambers are going to fill with blood. The heart is relaxed. During systole, this is contraction. So there's blood that's going to be pushed from one chamber to another, or out to the body, or out to the lungs possibly. All right. And you've probably seen these, at least if you haven't seen these specific words before, you've probably at least heard of them. Diastolic and systolic blood pressures. The systolic blood pressure is usually the top number. So say if you had a blood pressure of 120/80, 120 is the pressure exerted on the arteries during systole, right? During contraction of the heart. Now, diastolic blood pressure is usually the bottom number, so that'd be 80, right? And a 120/80 blood pressure. All right, so that's the pressure exerted on the walls of the arteries when the heart is relaxed. Now, during ventricular contraction or systole, the pressure is going to rise and the valves are going to open and blood is going to be ejected, right? And this becomes at least arises one key term as well: end systolic volume. And that is the amount of blood that is left over after systole. All right. And we're going to refer to this term here later on in the chapter. Now, during ventricular relaxation or diastole, the pressure is going to drop. The valves are actually going to close. And so the blood isn't really going to be going anywhere. All right, it's going to essentially be trapped in that chamber. Now, also end diastolic volume. This is going to be the volume that is in the chambers at the end of relaxation or end of diastole. All right, so you can see from the figure here, during systole, the pressure greatly increases pretty dramatically. All right, and then during relaxation, the pressure dramatically decreases. Now, down at the bottom, you can see where there's a certain volume of blood within the chamber. And then during systole, pressure increases, forcing a lot of that blood out, and it decreases significantly. And then during relaxation, it's able to fill back up. Right, and then during at the end of relaxation, there is the maximum amount of volume of blood within the chamber then. All right, so looking at these terms, end diastolic volume and end systolic volume, and why they're important. Well, it gives us an important number: stroke volume. All right, stroke volume is the amount of blood ejected during one heartbeat. And the best way to find this number is take end diastolic volume, so the amount that was left in the ventricles or during relaxation, and then the amount that was left over after contraction. All right, so not all the blood's actually going to be ejected. Now, it's good to keep improving this number, and becoming trained actually improves this number as well. Now, one key point to make is you can't just, I guess, figure this out all on your own. You kind of have to have some specialized equipment to at least estimate this. Usually, like a Doppler, you can even estimate during some possible EKG type of stuff, but you can't just guess on it too much and get a really accurate amount of end diastolic volume and systolic volume, or just overall stroke volume of yourself without actually going to a specialist. Now, another term is ejection fraction, and this is basically how efficient the heart is at pumping out the blood, the volume of blood. So you take the stroke volume and divide that by end diastolic volume. So if we take this example up here where we had a stroke volume of 60 milliliters per every beat. So plug in the 60 divided by 100 for the end diastolic volume, which is up here. Then you're going to multiply it by 100 then, and that'll give you 60% at rest. Now, I'm not going to have you actually calculate anything on exam. I want you to be able to understand the concepts of stroke volume, end diastolic volume, and systolic volume, ejection fraction, and what that is. So I'm not going to have you actually calculate something out like that because it's going to be important in understanding what happens as we begin to exercise and how all of these are affected. Now, if we look at cardiac output designated as Q is equal to stroke volume times the heart rate. All right, so cardiac output is the rate basically per minute, how much blood is being pumped out of the heart. So we take whatever our stroke volume is, which is the amount of blood ejected in one beat, times however many beats there were, all right, per minute. So if we take this example here, we had a resting heart rate of 70 beats per minute, a stroke volume of 70 milliliters per beat. So our cardiac output then is 70 times 70, which would give us 4,900 milliliters per minute. Now, this is still cardiac output, but usually cardiac output, because it's such a large number in terms of the amount of milliliters, we normally take it and divide it by 1,000 to get liters, just to make it a nice, neat number. Now, this is what I was describing before with systolic and diastolic blood pressures. Again, the systolic blood pressure is going to be the top number, and diastolic is the bottom number. Now, mean arterial pressure, or MAP, this is the average pressure exerted throughout the entire arterial tree. And you can get it by taking 2/3 diastolic plus 1/3 systolic blood pressure. The reason this number becomes important is that you can compare one number to another, data that is one number, and someone else's data that's one number versus two numbers. For example, if you wanted to compare someone who had a blood pressure of 118 over 70, and another person had 115 over 68, and another one had 124 over 83, you have two numbers for each person to try to compare. So which one is more important? Is it systolic, diastolic? All right. Getting an MAP, all right, puts it into one number. All right. So it averages it out instead of having two different numbers. All right. So it does make it a little bit easier to compare and contrast between different patients or different subjects, maybe within a study. If you're wondering, the normal, I guess right now it's actually considered pre-hypertension, which is 120 over 80. That comes out to be approximately 93.3 mean arterial pressure. However, in most cases, it's actually rounded up to 100. I don't know why it's actually rounded up clear up to 100. At least I don't know how much of an error that causes, but a lot of people will just use 100 if it's 120 over 80, just because it's a good number to be able to divide, multiply, subtract, all that stuff from. So anyway, now hypertension and hypotension. Hypertension is simply high blood pressure. All right. And there are different levels of increasing blood pressure. All right. Again, 120 over 80 right now is actually considered pre-hypertension. Back a few years ago, it was actually normotensive. All right. NORMO tensive. But now it's actually considered being at risk for developing hypertension. And hypotension is low blood pressure. Hypertension, you can get from a lot of exercise will cause your blood pressure to increase, as well as, or at least your acute blood pressure. Now, your resting blood pressure, exercise can actually help decrease that. Eating a bunch of junk food, fatty foods over an extended period of time can actually increase blood pressure, resting blood pressure. Hypotension usually will occur if there's some type of internal condition or injury, blood loss, internal blood loss, or even if you're bleeding out. Now, the pressure is going to be the driving force for the blood flow. All right, the heart's going to contract forcefully, giving it that drive to be pumped out through the rest of the body. And it's always going to go from a high pressure to a low pressure. That high pressure is going to be in the left ventricle and also in the arteries, especially in the aorta. And it's going to go to a low pressure in the veins and then to the right atria. And in fact, that opening between the vena cava and the right atria is about almost 0 millimeters of mercury. So it's a really, really low pressure. It's about usually anywhere from 0 to 1. All right. So it's going from a really high pressure right at the aorta to a really low pressure on the other end. So then the blood flow then is going to be equal to the change in pressure, which is basically that difference between the aorta and right there at the right atria. And also the resistance, because in between the beginning and the end, all right, kind of strange to say it that way, the beginning and the end, but it really is. It's starting off, the blood starting off coming up through the aorta, and it's going to basically come back to the heart through the vena cava. All right, in between there's a bunch of different things that can happen in terms of the resistance. The resistance could change, either decrease or increase significantly, depending on what's going on, and that will affect it. All right, so let's switch gears here and look at the electrical conductivity of the heart. So this is the intrinsic conduction. All right, so we actually have signals coming from the brain, all right? And this is part of the autonomic nervous system, the stuff that we don't need to think about. We don't need to think about contracting the heart. Now, there's things that we can do that increase or decrease our heart rate, but that's not necessarily voluntarily contracting the heart. We're not physically performing that action. So that signal will arrive at this node right here, which is the sinoatrial node, or SA node. It will then travel through the atria down to the AV node, or the atrioventricular node. It actually travels fairly quickly from the SA node to the AV node. And instead of just going from SA node to AV node and then bam, right into the right down into this structure, which is the interventricular septum, right? Basically the separation between the two ventricles. It's actually going to get to the AV node and pause just for a little bit. All right, 0.015 seconds or so. All right, it's going to pause and give the ventricles enough time to fill up with blood. All right, so essentially what I'm saying is that soon as the action potential goes from the SA node to the AV node, the atria will contract. If it went down into the nerves, going down into the septum and into the Purkinje fibers in the walls of the ventricles, it would cause the ventricles to contract at the same time that the atria has contract. So there's not going to be any blood flow anywhere. It's just going to, because there's going to be equal pressures pushing against that blood in the ventricles and the atria. So the ventricles need to be relaxed as long as possible to be able to pump out as much of the blood from the atria to get it into the ventricles. So that delay is to help aid ventricular filling. Now, once it's filled up, and once that delay has ceased, it will then travel down into the bundles, the AV bundles, and then down into the walls of the ventricles, into the Purkinje fibers, and then the ventricles will then contract. Now, the extrinsic control, this is where we're going to have the parasympathetic and sympathetic responses. Now, internally, the heart has its own system, intrinsic system of regulating the heart rate, and it's usually around 100 beats per minute. And you can see from the figure here, right? It's right around 100. This basically the red line right here, 100 beats per minute. That's the intrinsic heart rate. If we didn't have any response from either the parasympathetic nervous system or the sympathetic nervous system, our heart rate would be at 100. Now, with the parasympathetic response from the medulla oblongata in the brain, it's going to go down through the vagus nerve, and that actually carries impulses to the SA node and the AV nodes. And this causes a decrease in heart rate. Remember that the parasympathetic response in nervous system, that's a rest and digest response. The sympathetic is going to be fight or flight. So parasympathetic, we're resting, digesting. Our heart rate is going to be decreasing. All right, and this is the reason why it happens. All right, so it's going to depress the intrinsic heart rate. Right, and if you want to look this up, it causes a less spontaneous depolarization. Basically, if you go back to one of the chapters, we didn't really go into it too much. In fact, we didn't go over that chapter, but it was the chapter on the electrical system or the nervous system. And you can look at action potentials and all that, but basically it has to deal with the depolarization, and it's less of a spontaneous action potential that's going on, causing electrical stimulation. So, but really all you need to know is the parasympathetic, it's going to come down through the SA node and AV nodes, and it's going to depress the intrinsic heart rate. All right. So that's known as the vagal tone. Now, during exercise, during low intensity exercise, much of the increase in heart rate up to that intrinsic level, which is about 100 beats per minute, isn't necessarily due to the sympathetic response, all right, that fight or flight response. It's going to be due to just simply taking away that parasympathetic response. All right, so we're decreasing the amount of stimulation coming from the vagus nerve, and you can see that depicted in the figure here. Now, during higher intensity exercises, getting above 50% of your max exercise, that is going to be that increase in heart rate is going to be due to the sympathetic response. So the sympathetic nervous system, it carries impulses to the SA and AV nodes. And this is going to depolarize. Again, it has to do with the electrical conductivity, the nervous system. And it's going to depolarize due to a neurotransmitter known as norepinephrine. norepinephrine and epinephrine are known as the catecholamines. And they're very very powerful in the endocrine system. In this case, norepinephrine is used as a neurotransmitter. It's very powerful stimulation, all right, of stimulating electrical signals. So this causes the heart rate to increase, as well as the force of contraction of the heart. So not only are we pumping the heart faster, but it's more forceful. So we're getting as much blood out as possible, not only for each beat, but also every minute. And again, this is going to determine the heart rate during exercise or any type of stress. All right, it's fight or flight response. All right, so keep that in mind. The reason that it will increase if we're being chased by a grizzly bear is because of the sympathetic response. That doesn't mean we're exercising, we're moving. It's physical activity, but it is certainly stress. And really, if you think about it, that's all really exercise is stress. You're placing some type of stress on the body. Now, I referred to the endocrine system with norepinephrine and epinephrine. And again, these are the catecholamines. And epinephrine is also known as adrenaline, and norepinephrine is known as noradrenaline. They both act fairly similar. They have similar effects on the body and the heart rate. Now, they also have the same effect in the in the nervous system, sympathetic nervous system. But when released as hormones in the endocrine system, they actually last a lot longer. So instead of increasing the heart rate for 4, 5, 10 seconds, they'll actually keep the heart rate elevated for longer than that. Right, norepinephrine usually takes maybe a little bit longer to peak, but it lasts a lot longer. Epinephrine peaks really quickly, and it decreases fairly quickly. But again, the endocrine system and especially norepinephrine and epinephrine are very key during exercise. All right, cardiovascular responses to acute exercise. So there's increased blood flow to the working muscles. That is fairly apparent. I mean, you can feel a pump sometimes, especially during some type of strength training. You can feel a pump in the muscles, and that's increased blood flow. Now, there's an altered heart function because of this. So the heart rate going to be increased. Stroke volume, we'll see, is increased. Cardiac output is going to be increased. Blood pressure, increased. Blood flow is going to increase, at least to the working tissues or the muscles, the contracting muscles. Now, to some places, it's actually going to decrease. The blood, maybe not necessarily immediately, but fairly quickly, could change its content. We'll see that here in a little bit. Now, resting heart rate, usually around 60 to 80 beats per minute. All right, give or take a little bit. Someone who is really, really trained, going to have a really low heart rate. It could even be in the high 30s or the 40s. All right, someone who is really out of shape, it could be higher than 80. Now, there's also something else that you need to be aware of, is known as the anticipatory response. And what this does is actually decreases the vagal tone. So remember that that vagal tone is the suppression of the intrinsic heart rate that brings that heart rate down below 100 beats per minute. If you are thinking about exercise, if someone says, "Hey, I want to see how well you do in this type of exercise. I need you to get on a bike, all right, a stationary bicycle, and I'm going to measure your heart rate for this, exercise protocol." And they say, "Well, I'm going to take your heart rate, 15 seconds before you start exercising." Your heart rate's going to be increased above resting heart rate because you're already thinking about the exercise, right? Kind of that mind over matter type of thing. You're thinking about the exercise. You're starting to get a little bit pumped up for it. Your body's priming itself to get ready for the exercise. All right. You're anticipating it. So you release a little bit of norepinephrine and epinephrine, as well as decreasing that vagal tone. So that increases your heart rate. All right. So that's something to be aware of if you're taking heart rate right before somebody is exercising, is that it may be a little bit higher to begin with, just right before exercise, because they're thinking about it. They're anticipating that exercise. Now, heart rate is directly proportional to exercise intensity. Maximal heart rate is an all-out. You can get this with an all-out effort with volitional fatigue. Basically, you cannot go any further. If you're on a treadmill, that means you're basically almost falling off as soon as you say I'm done. All right. Now, this is going to decrease with age. It's going to decrease about 1 beat per year. All right. So to estimate it, take 220 minus your age, and that will get you your heart rate max. Now, this is an estimate. It's not exact. In fact, it can actually vary 10 to 15 beats plus or minus. Right. So if someone was, say, 20 years of age, their max heart rate for this equation, their estimated max heart rate is going to be 200. But it could be as low as 185, or it could be as high as 215. All right. So you got to kind of keep that in mind. It's an estimate. It's not an exact science, but it'll at least get you in the ballpark. Now, steady state heart rate, or a plateau. Basically, what this is describing is that we're not going to get up to the heart rate for a given exercise intensity immediately. Right? It's going to take a few minutes for our bodies, for our heart rate to get up to where we are meeting the demand of that exercise. All right, so our heart rate's going to continue to rise for 2, 3, possibly 4 minutes, and then it's going to start to plateau as long as we're not changing the intensity of the exercise. All right. So why this is important is we can actually use it to estimate VO2 at given exercise intensities. You get someone on a treadmill or a bike, and for each stage, you have them exercise at that intensity for 2 to 3 minutes at least. And then usually you have it for 4 minutes. And then at 3 minutes, that's when you start to take either heart rate or blood pressure. And that way it gives you a minute to kind of get all those data points before you jump up in intensity. So you can see what the steady state heart rate is, all right, where the heart rate is leveled off during those stages. And you can graph them out, and through different graphs, this is just one in particular, but there are a couple other ones that you can use to estimate. And you basically just get at least 3 data points and extrapolate the line out, and then drop it perpendicular to down to another graph that is a scale that is below the graph. And you can get a rough estimate, a fairly decent estimate of what your oxygen uptake is, or your VO2 max is, your volume of oxygen that you're able to use is. Now, in this case, you can see that subject A had a low heart rate compared to subject B at a given exercise intensity. So this is 50 watts, 150 watts. This would have been 75 watts. You can see that their heart rate was lower at those intensities. That usually indicates that person is in better condition, better aerobic condition. All right. So subject A is probably more fit than subject B. And again, if you extrapolate those lines out, subject B's line is going to hit the predicted heart rate max before subject A. So if you drop that line down, their VO2 is lower than subject A. So again, you can use the steady state heart rate for predictors in conditioning. All right, so looking at stroke volume, again, going back to the equation, stroke volume equals N diastolic volume minus N systolic volume. So anytime that we're going to change either N systolic volume or N diastolic volume, we're going to change stroke volume. All right, venous return is basically the blood coming back from the veins. All right, going into the vena cava. All right, so during exercise, our blood's being pumped out of the heart and through the body at a more rapid pace. More of it's going around the vascular tree, so more of it's going to be coming back. All right, more of it that comes back to the heart, the more of it that there's going to be during diastole. So the end diastolic volume will increase. All right, so that increase in venous return causes the increase in end diastolic volume. There's also going to be an increase in distensibility, basically the stretching out of the cardiac wall within the chambers. All right, especially in the ventricles. All right, so during diastole, there's going to be a lot more pressure because there's more blood there coming back to the heart, filling the ventricles up. So they're going to be a little bit more distended. They're going to stretch out just a little bit more, so that also causes the end diastolic volume to increase. Now, there's also going to be a greater contractility within the ventricles, and we'll see why here in a second. But this will increase the ejection fraction as well as decreasing the amount of blood that is left over after we've had contraction. Now, there's also going to be a decrease in resistance in the aorta and also the pulmonary arteries. They're going to vasodilate, so they're going to get a little bit wider, at least the lumen, the hole for the blood to flow through is going to get a little bit wider, so the resistance is going to be decreased. So that distensibility that is caused by the increase in blood, right? That slight stretch of the cardiac fiber muscles. Right? If we think back to skeletal muscle fibers, if we have a muscle that is slightly stretched, we have a good myosin to actin ratio and cross bridging. And it's going to be the same concept here. We have that slight stretch because of that increase in end diastolic volume, or also known as preload. And we're going to have what's known as the Frank-Starling mechanism. And we're going to have an increase in the force of contraction because we've slightly stretched that cardiac muscle fibers. And now we have an increase in actin-myosin cross-bridging forming, thus an increase in muscular contraction. Now, this is only necessarily going to occur at low to moderate intensities. And the reason that is because during low and moderate intensities, the heart rate is low enough to where we have time to be able to fill up the ventricles with a good amount of blood. Once we start getting into really high intensity exercises and our heart rate skyrockets and gets really close to max heart rate, we're not going to have enough time to fill up the heart with a lot of blood. All right, so this Frank-Starling mechanism, this stretching, isn't necessarily going to occur so much at higher intensities. In fact, once we get to max, it's not going to occur because we just don't have enough time to fill up the ventricles with blood. Now, during higher intensity exercises, we're going to have an increased contractility because of the increase in norepinephrine and epinephrine. The catecholamines are going to be released at really high amounts. All right, so we're going to increase the force of contraction that way. The ejection fraction will increase as well. So we're going to be pumping out a good amount of that blood that is left over at the end of diastole. All right, so this is during moderate to higher intensity exercises. There's also going to be a decrease in peripheral resistance, basically looking at how vasoconstricted, all right, or the tightening up of the smooth muscles within the blood vessels in the vascular tree. They're going to open up a little bit as well. So there's going to be a decreased resistance there. Now, if you look at stroke volume over here in this chart, as we increase intensity, the VO2 max down here in the x-axis, which is basically increasing intensity, you can see that it doesn't increase linearly. It doesn't just continue to rise as we increase intensity. Usually around 40 to 60% of your VO2 max, it's going to plateau. All right. So in that range is going to vary individual to individual, but 40 to 60%, it's usually going to plateau, and it's not going to increase very, very significantly past that point. Now, looking at cardiac output, again, cardiac output is heart rate times the stroke volume. Again, it is going to be the amount of blood being pumped out per minute. This is going to increase with increased exercise intensities, and it's actually going to plateau near your VO2 max. And in fact, this could be this is one of the limiting factors in determining how high your VO2 max really is, right? Because that blood within that blood is going to be oxygen. And if we can't get the blood out very quickly, or at least a large amount of it per minute, then our VO2 max isn't going to be very high, because we're not going to be able to meet the demand of that high intensity. So the max of this is going to depend on the size and also your aerobic conditioning or fitness. So a figure from your book, kind of describing what I talked about in the last few slides here. So if we look at cardiac output and look at some of the things that's going to affect it. Again, cardiac output is equal to the cardiac rate or heart rate times stroke volume. Now, looking at cardiac rate or heart rate, the parasympathetic nerves, all right, are going to affect it. All right, if we, at least the extrinsic control of the parasympathetic response is to decrease the intrinsic heart rate, right? Getting a vagal tone, so decreasing it below 100 beats per minute. If we take away this response, it's going to increase it up to the intrinsic heart rate, close to 100 beats per minute. Now, the sympathetic nerves will also cause an increase in heart rate at higher exercise intensities. It'll also cause strength contraction, all right, causing the stroke volume to increase. Now, we're going to have some type of stretch because of and then causing the Frank-Starling mechanism to occur. And again, that's all because of the increase in venous return, blood coming back to the heart. So that's going to cause it to stretch. Going to cause the force of contraction to increase, causing stroke volume to increase. Now, also mean arterial pressure. If we increase mean arterial pressure, we're going to decrease stroke volume. There's not going to be as big of a hole, basically, for the blood to pump through. It's going to have to kind of squeeze through a smaller diameter hole. But the pressure, if it decreases, generally we're going to be vasodilating the blood vessels, and that'll help to increase stroke volume. All right, so if we look at what's happening during increasing exercise intensities, so all of these are going to be based off a percentage of VO2 max, 25, 50, 75, and then 100, which would be max exercise intensity. So we got blood pressure up at the top. Systolic is going to be increasing, as well as mean arterial pressure, going to increase fairly linearly with exercise intensity. Now, looking at stroke volume, it's going to increase up to about 40 to 60% VO2 max, and then it's going to start to plateau. Cardiac output, it's generally going to be linearly increased. Now, once we get to this point, because stroke volume is part of cardiac output, it's going to start to level off a little bit, but it's not necessarily going to plateau. All right, so we're going to be making up for this plateau in stroke volume by an increase in the heart rate, which is going to be proportional to the exercise intensity. And we'll get to this AVO2 difference later on, but the AVO2 difference, basically the difference between the amount of oxygen that is in the arteries versus the amount of oxygen that is in the veins. All right, and that is going to be changed because we're going to be using oxygen once it gets to the muscles, and then it's going to go into the veins, and going to be less oxygen. All right, so that AVO2 difference is actually going to be increased. All right, so looking at the responses, the mean arterial pressure is going to increase, and we've seen that before on the previous one, but keep in mind that the diastolic response, let me go back to this figure, the diastolic response does not change. Now, there might be some slight differences, increases, decreases here and there, but generally speaking, there's not going to be any change in the blood pressure during diastole. If there are certain diseases, such as maybe blocked arteries, hardening of the arteries, then yes, there could be some increase. And in fact, if diastolic blood pressure increases too much, that is indicative of some type of cardiovascular condition. But the mean arterial pressure is going to be increasing mostly in the systolic blood pressure, and that's going to be caused by the increase in the cardiac output. Even though we might have some dilation within the vascular tree, there's still a lot more blood being pumped out. So naturally, the pressure is going to increase. Now, there's an increase in cardiac output and blood pressure for the working muscles. All right, and that's the whole point of all this. The tissues, being the muscles in this case, when we talk about physical activity, they need more blood because within that blood, there's nutrients and oxygen. And we also need to get rid of carbon dioxide. So they need to increase to meet that demand to keep them working properly. So we're going to have this blood flow redistribution because we only have so much blood within our bodies, and we need to maximize the usage of it. All right, during resting, we're going to have a lot of it basically within the gut. We're going to have some during, gut flowing all over the body. If we don't have any blood flow to a certain area, it's obviously going to die. It's not going to get oxygen, not going to get the fuel necessary. But we have a good portion of it within the gut, or what's known as the splanchnic region. All right, so that's actually going to shift from the gut out to the muscles. And some of this has to do with pH content, carbon dioxide content, temperature will affect this, and also pressure of oxygen. And we'll see that in chapter 10 about the PO2, all right, essentially the concentration of oxygen. All right, so if we look at differences here, and this is a fairly simple figure to look at. So if we have the percentage of VO2 basically increasing exercise intensity, the amount of blood flow going to the muscles is greatly increased from rest to exercise, and also during increasing exercise intensities, and it's going to be dropping in the splanchnic region. Get another figure to describe this. During heavy exercise, if we look at the blood flow in the gut, 3 to 5%. Right? If we look at the blood flow to the muscles during heavy exercise, we get 80 to 85%. Now, if we look at resting, we got about 20, 25% in the gut and 15 to 20% in the muscles. All right, so during rest, we're going to be basically pumping more blood to areas that aren't necessary, that are needed during rest, such as digesting food, filtering out stuff with the kidneys, the bones. Basically, the heart's not necessarily going to change all that much. The brain, we actually decrease the amount of blood flow to the brain as we exercise as well. So again, there's this shift, and most of it's coming from the gut and being redistributed to the muscles. So we have this change in resistance, and the reason we redistribute the blood, or how we redistribute the blood, is going to be based on vasoconstriction and vasodilation, either constricting the blood vessels or dilating the blood vessels. So that's where we're going to redistribute them. And in fact, arterioles are going to be are going to help affect the local blood flow changes in certain areas to redirect the blood to certain areas, either basically cutting off as much blood flow to some areas while opening up to allow more blood flow to other areas. Now, some factors that will affect these arterial vasodilation, vasoconstrictions, uh, for the intrinsic, if you look at the metabolic byproducts that can be produced for vasodilation, the amount of oxygen can actually cause vasodilation. Carbon dioxide, potassium, hydrogen ions, lactic acid, those can all help to increase vasodilation. Are also endothelial mechanisms that'll help cause vasodilation. Nitric oxide is going to be the big one here. And there's some certain supplements that actually have some theory behind this. Weightlifting supplements, strength training supplements that promote, or that, I mean, the companies themselves promote it as being a way to increase muscle size. Basically, the principle behind this is that if your blood vessels are dilated throughout the day through the within the muscles, all right, so you take this product and it helps, and it has nitric oxide or some derivative of nitric oxide in it, and it'll vasodilate the blood vessels within the muscles. And the theory is, if you vasodilate them, that means there's more blood flow to the muscles, more food particles, more nutrients, oxygen. Everything is going to the muscles through the entire day instead of just after the workout, because you can get the same response after a workout. Muscles are all pumped up and they're nice and hard. But some of the products don't necessarily work that way. Whether there's some truth behind some of them, there's at least theoretically it should work, but the research isn't really shown that. Now, there is one product that basically did this, and it's also it was actually used as it was formulated as a drug to help with decreasing blood pressure, because the vasodilation will help to decrease blood pressure. So if you vasodilated the blood vessels, your hypertension should be relieved, at least to a certain extent. Well, most studies are going to be on men, so they at least initially, unless it's really formulated for females or different circumstances like that. But they gave it to a lot of guys, and the guy said, well, I don't know what my blood pressure is like, but something else is going on. What they were finding was that the guys were taking this and they were also getting erections. And this was the beginning of Viagra. So Viagra basically started off as a blood pressure medication. That's what it was studied for. And that's what the mechanism was basically helping to release nitric oxide. But for some reason, it was just dedicated and it was centralized in one certain location. So anyway, that's your fun fact for the presentation. Now, there could also be a myogenic response based of basically vasodilation or vasoconstriction because of any type of response to pressure. All right, it's just going to depend on what the response is. It's going to be dependent on certain locations. Now, the extrinsic control, this is going to be the sympathetic or parasympathetic responses. And in fact, it's more so the sympathetic response is going to increase vasoconstriction. And if you just take away the sympathetic activity, you're going to decrease vasoconstriction. All right, venous return. I described this early on when we discussed end diastolic volume. If we increase end diastolic volume, it's going to lead to increased force of contraction and then increased stroke volume, all that good stuff. So how do we increase venous return? There's three ways in our bodies that we promote an increase in venous return. And they're outlined in this figure. All right, so we have the skeletal muscle pump. Basically, if you look at this, these figures here, these pictures, if you look at these muscles as being muscles within the lower body, within the legs, Every time that you squeeze the muscles, you're basically milking and squeezing the blood up, because the blood needs to overcome the force of gravity a little bit. So if we weren't squeezing the blood, it would be a little bit slower at moving up towards the heart, back to the heart. So the skeletal muscles help with that. And just a simple act of walking and running, that will cause that milking, all right, or that pumping of the blood because of the skeletal muscle pump. Now, also kind of depicted in here, but you kind of have to use your imagination a little bit, is the respiratory pump. So think of the muscles as the muscles within the thoracic cavity, basically the chest cavity or the abdomen. So anytime that you breathe, all right, you're contracting those muscles, and that helps to basically squeeze and milk the blood back up to the heart. And the last one will be the venous valves, and these are depicted in the veins here. So what's happening is that as the blood's being pumped up, there's going to be some small valves in the veins that when it gets up to a certain area, between beats, it's actually going to be falling down slightly. If these valves weren't here, it would pump up and then pump down, and it'd just keep on going like this. It wouldn't hardly move anywhere. So having these veins, it goes up, and there's no way for it to leak back down any further. And then along with the muscles in the respiratory pump, it can help keep pushing it back up through. All right. Now, there are certain conditions where these valves become a little bit weak over time. If you stand for long periods of time, chronically speaking, they can get really weak. Some blood can leak back down. And you can also develop what's known as varicose veins with that. Now, if you look at fighter pilots, you can see videos of this online. If you see them and they're kind of breathing really weird, like, you almost need to see me. All right. Sitting at my desk trying to breathe like a fighter pilot and trying to describe it to you. But anyway, look up some of these videos. You'll see them, really breathing, forcefully. And what they're doing is that respiratory pump. They're trying to force the blood the best they can up to the vena cava. And the reason that is when they're banking, going around a turn at 8-9 Gs, this blood, it does not want to keep on pumping upward. It wants to be pumped down towards the feet. At the same time, they're also contracting forcefully the muscles within their lower body to aid in venous return as well. So again, the three things that help with increasing venous return: skeletal muscle pump, respiratory pump, and the venous valves. All right, so looking at the blood itself, so this medium that we have. All right, there's going to be two components. All right, the plasma and the formed elements. So the plasma is going to make up about 55 to 60% of it. This is actually decreased with dehydration. When we sweat, this is what we're losing, is the plasma volume. So if we sweat too much, we start to lose that plasma and the blood becomes less liquid. And it actually becomes a little more sludgy, and it can be hard to pump sometimes. Now with training, as well as heat acclimatization, basically your body adapting to a hot environment, this actually increases more so over before you were trained or before you were acclimated to that environment. Now, the formed elements make up about basically the other half of it, 40 to 45% of it. Now, these are going to contain the red blood cells or the erythrocytes, white blood cells, the platelets. Now, the total percentage of this volume is going to be known as the hematocrit. All right, so hematocrit isn't necessarily a number of particles or or volume, but it's basically the percentage that these formed elements make up of the entire blood. Now, looking at red blood cells, because this is kind of a key point in oxygen transport, and what we always talk about with the VO2 and all that stuff. This is how we get the oxygen floating around in the blood. Right? The red blood cells, they don't have a nucleus; they can't reproduce. They're going to be produced, destroyed equally. We're just going to get rid of them, and we're going to make new ones. Now, within the red blood cells, we have what's known as hemoglobin. We have basically part of heme and globin, which is a protein. All right, so we're going to have 4 oxygen molecules for every hemoglobin, and that's because there's going to be 4 iron molecules basically bound or part of that structure within the heme. So the oxygen is actually going to bind to the iron molecules that are in the heme. Now, for the viscosity of this blood, viscosity is just basically thickness, how well it runs or flows. So if we increase the viscosity, it's going to be harder to flow. It's going to be a little sludgy. If we decrease the viscosity, it's going to be more watery, easier to flow. So if we increase the hematocrit, right, that percentage of the formed elements versus the total blood volume, the viscosity is going to increase. That's going to decrease the flow. It's also going to decrease the rate of the oxygen transport. Those oxygen molecules that are bound to iron are not going to be able to be transported as quickly because the blood's not going to be able to be flowed very quickly through the blood vessels. All right, so it's okay. This hematocrit's okay up until it reaches about 60%. That's the point where it starts about the point where it starts to get almost too sludgy to be able to meet the flow, the blood flow demands that are necessary. So with this, we need to introduce more plasma to the blood so that we can get it to flow correctly. Now, if we decrease the hematocrit, we decrease the viscosity. This increases the blood flow, but it also decreases oxygen carrying capacity, or at least it could. So again, the hematocrit is going to be the percentage of the particles within the blood compared to the total blood volume. All right. If this blood volume stays the same and we end up decreasing this, all right, but then we still increase the plasma volume, then we're not going to have as much hemoglobin to take oxygen and carry it to the working muscles. All right, so that's just because it's a low viscosity, it's able to flow faster, doesn't necessarily mean it's going to be 100% advantageous. Now, it could be down to a certain point, right? Because it is flowing faster, and you're able to make up for the decrease in the oxygen carrying capacity because since we don't have enough hemoglobin, or we're able to make up for that, right? But at a certain point, it's going to be too low, or we don't have enough oxygen that is bound to the available hemoglobin. So at that point, we need to increase the amount of hematocrit. Now, there's going to be optimal levels. Basically, low to normal hematocrit is going to be good. It's not going to be too watery. We're not going to have, we're going to have a good amount of hemoglobin for oxygen to attach to. And it's not going to be too sludgy so that it's not going to flow really slow either. So there's going to be an optimal level there, basically a Goldilocks effect with hematocrit. All right, so that was Chapter 9, Circulatory Responses to Exercise. And if you have any questions, you can put a comment down below the video here, or you can email me if you want. Again, I thank you for listening. And again, that was Chapter 9.